Hello, everybody. Thank you very much for joining me today for this presentation titled Cerabone Plus in Regenerative Implantology. First of all, I would like to thank Bautis for having me here to show my experiences. I'm going to show a few clinical cases with you, and also for having involved me in the early stages of the use of this new biomaterial. Great. So what's different about Cerabone Plus if we compare it to the original Cerabone? So if you have ever used Cerabone, you know it's a xenograft particulate. And what's different this time is that this material has been combined with hyaluronic acid. So I think that mainly has two good outcomes. And one is the clinical application. And what I like most of it is that it becomes a sticky bone very, very easily when we hydrate the Cerabone Plus. It can be either with blood or with saline. And it really minimizes the displacement of the granules during GBR or any kind of bone grafting techniques. It's very easy to do. It's done in a matter of a few seconds, and it becomes this sticky, malleable paste. It doesn't really set into a hard cement. So there's no time or there's no limit in which you can apply it into the defect. And this is my first case. So I want to show you that this is done in real life. And there's no training, there's no learning curve to it. Like anybody can do it in a very, very simple way. So here I'm just adding a few drops of saline to the Cerabone. And if you compare this, for example, to using PRF or PRGF, any techniques that require drying blood, well, you're saving a lot of time to prepare this sticky bone compared to the alternatives. So here you go. You can see very simple way. All the granules have become compact in like a malleable mass. And there's also some evidence that the hyaluronic acid, so we've spoken until now about how clinically physical properties are very, very advantageous. But at the same time, there's some evidence that this hyaluronic acid, it helps the osteoblast get active and work and help us towards the proliferation and regeneration in our bone defects. Just to briefly introduce myself, I practice implant dentistry, private practice in Dublin, in Ireland, and I place implants as well as I restore them. And I carry out considerable amount of bone and soft tissue grafting procedures from simple to more complex. In my spare time, I also dedicate myself to training other colleagues in advanced bone and soft tissue grafting. We also do, or we carry out some live surgery sessions in the clinic. And with all this, well, it's fantastic to meet other colleagues and share my experiences. If you have used xenografts or if you use them regularly, you know that they come in most likely particulate forms like this with interconnected pores. And xenografts are used very, very widely in regeneration. They're used from socket preservation to sinus lifting to horizontal and sometimes even vertical regeneration. But we had to understand how xenografts they perform and what kind of limitations they have, because we know that these particular materials are purely osteoconductive. And that means that we apply them onto the natural or the host bone, and the only thing they're doing for us is maintaining space. So we are relying 100% on that host bone in growing blood vessels and growing bone into these structures or these materials. So we need a prolonged barrier effect, and we need also a host bone with a very high osteogenic potential. Unfortunately, any biomaterials, or most of them, especially the xenografts, they have no osteoinductivity. That means they have no capacity to release signals, to release BMPs, growth factors, that will trigger the bone regeneration cascade in the host bone. So they're inert materials that simply maintain space. And of course, they don't have any osteogenic potential either. So once we understand all this and we understand what kind of biomaterials we have out there, we can mix and match and use them to our benefit. Another thing we know about xenografts is that this article, I think, highlights this characteristic very, very well. It's a very well done written article I would recommend to anybody that's using xenografts, is that once a xenograft becomes integrated within the bone, it doesn't really change form or resorb over time. So in this article, they harvested biopsies from sinus lifts done 11 years ago with xenograft materials. And what they found is that there was absolutely no change in the particle number or size. And this is evidencing that these xenograft materials, once they're incorporated in the bone, they don't resorb. That can be an advantage in some cases. So for example, inside a sinus where we want to maintain the volume, we don't want the sinus to re-pneumatize. It's good. Also, this bone will be not in the most critical area of the implant. It will be in the apical third or apical half, but we still maintain some natural autogenous bone in the crestal portion. But what about a case like this, right? Especially on the right side, where we are missing the buccal plate completely on one of the implants. If we simply place 100% xenograft, we had to expect and we had to allow for the host bone to fill in that cavity or fill in that defect completely with new blood vessels, new blood cells, and to integrate and not transform, but integrate and incorporate that xenograft into a new area of vital bone. As we know, the xenografts, they will not resorb. They'll be taking lots of space from that vital bone. So the less vital bone we have in an area, the poorer quality that bone will have. And in these areas, that bit of bone that's surrounding our implants will be in a very crucial, very critical area. So we want to have the best bone quality possible. Or for example, if we're going to attempt to do a vertical graft in a case like this, where we had to grow 6-7 millimeters of bone, if we're using purely an osteoconductive material that is not going to resorb, we're going to end up with less vital bone just where our implants will be placed. So long-term, we're not too sure how that's going to bear load, how that can fight bacteria. I like to follow a more biological approach, and this is another case that highlights what kind of situations we can find occasionally from using xenograft. So this patient got a xenograft graft in both those defects about 8 or 9 years ago and came back to do their implants. And upon flap reflection, the xenograft material was integrated in soft tissue. It was encapsulated in soft tissue. It hadn't resorbed in all this time, and it had to be all cleaned out to start the grafts again. This is another one of my cases where a horizontal bone graft was done with some xenograft, and 10 months after, using a slow resorbing rigid membrane, you can see that there's still a lot of xenograft in that area. So if this doesn't look like real bone, it might not work as real bone either long term. So we have to understand that, and we have to be critical with what kind of bone we want to get around our implants. The one thing I think is fantastic about Botiss is that they are honest and open about this issue. So this comes from Botiss, not from me. No single bone graft material or membrane is ideal for our situation. So there's no magic dust, there's no powder, there's no syringe that will be giving us the best result in every single indication. And that's why Botiss has an ample range of different biomaterials, from xenograft to allograft and synthetic, and also particulate form, thin plates to create our shell or split bone block technique, solid blocks, and resorbable and non-resorbable membranes as well. And I'm pretty sure that if they could sell autogenous bone, they would be into that as well. But that's something that the clinician has to harvest and work for themselves. But the clear message here is that no xenograft, no biomaterial is the best for every single indication. So that's why I like to follow a more biological approach, which is also evidence-based. So whenever I have a defect like this, we place our implant. It's a very, very common situation where we can have some threads exposed. We can see through the bone, we can see some darkness because the bone is very thin and the underlying titanium is nearly exposed. So in these cases, we rather place 100% autogenous bone first, okay, autogenous bone to completely reestablish that defect or completely fill that defect all the way to the top with autogenous bone, because it's the best bone material which will be in contact with the implant. It has osteoinductive mainly, and also some osteogenic potential to remodel or grow bone into this area very, very quickly. But at the same time, especially we want to maintain volume and contour, and following the principles of our own bone, which has a cortical layer, and then we have spongy or cancellous bone underneath. If we add some xenograft over this, 1 to 2 millimeters of xenograft, it is shown that long-term volume stability is going to be very well maintained. And if this xenograft becomes now integrated, because it's not lying simply on a piece of titanium, but it has a bed of living osteoblast and living bone underneath, it can become integrated and incorporated into the surrounding bone much, much more predictably. This will maintain our volume and contours long term. So let's think biologically, and let's think of what the bone looks like. We have the cortical layer and the cancellous layer, and we can try to reestablish this by using different biomaterials. Great. So as I've explained a bit, my ethos, how I work with xenografts and how I use them into my everyday cases, I have 4 clinical cases lined up today. The first 2 will be simple-ish regeneration cases in the anterior maxilla. And the last 2 cases, we're going to focus in the posterior mandible on more advanced atrophies and how to manage those cases, and how cerabone plus and how xenografts can really help us enhance our results. So in the first case, you can see a central incisor which has a considerable recession. It was root canaled, therefore the discoloration in the root, and the tooth has been nearly pushed out. It's over erupted due to quite a large infection that's underneath. Having a look at the CT scan, clearly for me, that would not be a case for an immediate implant. We have considerable bone loss, there is infection, and we're going to end up with possibly a horizontal bone defect on the buccal side. So the first step here would be simply to extract the tooth. I like to just let these areas heal on their own whenever I can, because I want to get the soft tissues to heal as quick as possible and get the best quality soft tissue I can. And interesting enough, this patient disappeared for 2 years. He got the extraction, got a temporary denture, and disappeared for 2 years. And it's one of those patients that you wonder whatever happened to them, if they were going to come back or not. But on and on, 2 years later, they came back, and this was the clinical aspect. So you can see at least that the tissue, the soft tissue, has bounced back. It has very, very nicely filled up that defect. We had a very big recession, and simply by extracting the tooth, allowing for the site to heal, the infection to resolve, we've ended up with thick, healthy, and good-looking soft tissue. So that's going to help us. It's going to work in our favor. It's going to help us to create the right emergence on our implants. And surely, if we're going to do any bone grafting, it's going to allow us to cover that bone grafting in a safer way. We're going to jump into a short video next, and I'm going to show you how at this stage now the implant was placed, because I was able to place the implant in the right 3D position, and a simultaneous GBR or guided bone regeneration was carried out with, as I explained before, a first layer of autogenous chips and then some cerabone plus over. Let me just silence this, sorry for that, very good. Occlusal view, clear horizontal defect. And the first step would be to elevate the flap. So not to say we had to be extremely gentle here. We had to try to preserve the tissue as intact as possible. And in the buccal surface, where we had the bone defect, there were some adherences. We had to very gently release that. Next, and before I do any grafting, before I start to lay any particles, I like to do my periosteal release. And there are a few reasons for that. The first one is that periosteal release will cause bleeding. So if we do the periosteal release very close to the suture, that bleeding will stay internally within the regenerative area, and it's going to cause more edema, and it's going to cause also more bruising. Whereas if I do my periosteal release now, by the time we are suturing, that bleeding would have nearly ceased. The second reason is because I like to see what I'm doing. So you can see how I'm lifting the flap to see underneath. And if I have quite a bit of biomaterial in there, it's impeding me from seeing properly. And especially if we're going to use, for example, a regular xenograft, which is not sticky, and you have places xenograft, there's plenty of bleeding in there, that bleeding will start to displace the particles. That's something that we can overcome with cerabone plus, but still I like to do my release first. I like to get my bone ready, my tissue ready, and only then start or continue with my implant and finalize with the regeneration procedure. You've seen me use a blade first, so I'm going to go with the blade from one side all the way to the other, continuing in the same plane or at the same level. And if there's still any adherences, then we're going to move on to a blunt instrument, and we're going to try to separate any fibers from the separated flap coronally from the base of the flap. This takes a few minutes. I had to be patient, and I can't insist enough on how important it is to see what we are doing. And that for me is a very acceptable, it's a perfect release for a horizontal graft. Now that the tissues are ready, I just had to simply focus on placing the implant in the right 3D position. I'm gonna do part of the drilling in a slow drilling protocol using a very low RPM, and that will allow me to collect some chips, some bone chips that I can use to cover any exposed threads that I might end up with. For a central incisor, this is a 4.1 times 12 implant. I think it's a very, very valid size implant. And we're going to gently, with patience, place the implant into the osteotomy, taking care to place it at the correct apicocoronal depth. The transporter here has 3 dots. Each one corresponds to 1 millimeter. So the third dot should be more or less aligned with the cervical margin or the desired future cervical margin. The next step, I'm going to connect a 2 millimeter healing cap, and this healing cap will act as a bit of tenting. It's going to help me to support and maintain the space for my membrane and the biomaterial. I also always like to tack in and place my membrane first. The reason for it is that if you place your biomaterial and then at the end you're going to start tacking your membrane, you can put undesired pressure. You can move around the biomaterial in ways that you don't want to. And once the membrane is fixed, you see me how I was applying a bit of autogenous chips directly onto the titanium surface. You have seen this before, but again, I'm going to hydrate my cerabone plus, a few drops. This takes 0.5 milliliters of saline. You can use blood instead. You can use the BCM, the bone condition media, whatever you think is working good for you. But the key aspect is that it's very, very quick. And once you mix it all together, it gets into this nice malleable mass. You can manipulate it with tweezers, you can shape it up, use your fingers if you need to. And now that it's all ready, we're going to apply it to the defect area. So you see how I just simply pick it up with the instrument. I'm going to place it in position. And this is why I like to have my membrane tacked already, okay? Because I'm going to tuck this biomaterial under the membrane. I'm going to position it, and the membrane will stop it from going any more apically. Very gently, I don't want to squash or I don't want to displace the autogenous bone that's underneath either. So I'm going to just gently shape and adapt it to the defect. And you're appreciating here that the particles, they're all binding and sticking together, which is great. It just makes it easier. and quicker to apply the biomaterial. I don't like to over contour too much. I think 1 to 2 millimeters is plenty. And of course, I'm going to then fix my membrane in the palatal aspect, and I'm going to add a bit of tension. I'm going to try to stretch it here. This is the Jason membrane. It's a very thin membrane, but at the same time, it's very elastic, and it's very resistant to tear and breaking. So we can stretch it and we can adapt it to the defects quite nicely. Whether you're tacking it, you're using sutures or a combination. And once I stretch it, that's compacting and it's keeping all my grafting material in the one place. And my membranes is extending to the adjacent teeth as well. Great, so that's the area sutured and closed. And from here, we're gonna move on to the exposure. So about 3 months later, the implant would be well integrated. We know that that xenograft material is yet not integrated, so we're not opening a big flap. We don't want to disturb it. So what's going to happen here is I'm going to do a small aggressive incision. I'm going to remove the cover screw without releasing or without lifting the papillas, and a healing cap will be connected. This is a couple of weeks after, just before the fitting of the tooth. And this is immediately after fitting the screw retain restoration. So there's a bit of blanching on the tissues, but the quality, the health, and the volume of the tissues are looking very favorable. The gingival margins of the two central incisors are pretty much matching, which is great. The pillars are acceptable. So I would be quite happy with a result like this. And from a buccal lingual dimension, you can also appreciate that the lost volume has been reestablished very nicely. No soft tissue graft was done in this case, just we allowed the site to heal on its own, and then we did some contour augmentation with the cerabone plus. That's the before and after. So from a quite an aesthetic issue, we've ended up with a very reasonable result, and the patient is happy. This is the immediate X-ray after fitting a tooth, showing us good bone stability. And 6 months after, or in the 6 months follow-up, you might notice that the patient also had got restorations on the other central and the lateral incisors, but the tissues are looking good. We have a nice color, and the volume and the quality of the tissues is being maintained very, very nicely. From here, I'm going to move on to the second case. The second case is quite similar, I have to say. So in this case, we have a central incisor that's already missing. The tooth was taken out a year or 2 years ago, and we have quite a good soft tissue height, but there's a bit of horizontal deficiency. And that can be seen on the CBCT quite well. There is also a metal artifact, and that metal artifact is pretty much where the implant is going to be placed. So imagine that once we remove the artifact, there's going to be a few exposed threads and buccal. Also, notice that I have placed the implant in the right 3D position. There's plenty of bone to place it more palatally, but that would end up with a bulky restoration in palatal and without addressing or without correcting the tissue deficiency we have in buccal. In the apical third and apical middle of the implant, you can appreciate that the threads are nearly fenestrated or nearly have gone through the buccal plate. And that's the area where we're going to have to correct the volume deficiency. Occlusally, the same issue can be seen. So the metal artifact is exactly where the implant is going to be placed. So yes, of course, we're going to remove it. But once the implant goes, we're going to have a few exposed threads. I'm going to ideally like to reestablish the contour of the ridge with the best biomaterial available, which is autogenous bone from the patient. But for long-term stability, we can also add a bit of, or a thin layer of xenograft, which will allow us to over contour a bit and compensate for the volume loss that results from losing a tooth. So remember, we're going to have an implant. There's no root underneath. There's no root that's going to support the tissue. So we have to help ourselves with some kind of volume. In this case, a xenograft will help us very, very well. Upon the flap reflection and removing the metal artifacts, you can appreciate the concavity, the crestal defect that removal of metal has caused. and that's the implant placed. On the left side, clearly visible is the darkness of the titanium through the bone on the buccal plate, more apical area. But in the coronal aspect, we have a few threads exposed, and we don't want to leave this uncovered. Great. So just as I did before, we're going to cover this whole area. We're going to reestablish, regraft the entire volume with autogenous bone. And in this particular case, it was a mix of bone coming from drilling, but as I needed more volume of bone, a scraping or a safe scraper was used to collect bone from adjacent areas as well. And the bone quality we obtain from the safe scraper is always superior to what we get from drilling. Anyway, that is all filled up with the autogenous bone. And very same way as we did before, we're going to incorporate, we're going to cover this with the cerabone plus. I said before as well, I don't like to over contour too much, because if we bulk out the xenograft or any biomaterial too much, it's just going to be putting loads of pressure into the graft, the lip, movement, the cheeks, anything would be putting pressure and it can displace the graft. But instead, I like to overextend my graft. So if we overextend the graft, I'm increasing the area of the graft. I'm going to be reducing the pressure that that entire graft is receiving. You're going to see how my graft is being extended over the lateral incisor, because there was also a concavity there. It's very typical. Lateral incisors will show a bit of a concavity. And I have moved part of the xenograft over the adjacent central incisor as well. Once all this is sutured and it's tight and tacked, we're going to remove any excessive biomaterial from the margins of the membrane. And now it's ready to suture. The suture has to be taken or has to be done with great care as well. We had to try to adapt all the margins of the wound perfectly to minimize scarring, to minimize papillary recession. And for this, I use a combination of sutures. I like to use resorbable sutures in the vertical release or papillary areas, and I like to use non-resorbable sutures in the more coronal aspect. And in 3 months, we go straight to finish, straight to the final crown again. We can appreciate nice papillas, good contour, patient is satisfied, and we are as well. Great, so we have seen 2 cases of implants with simultaneous GBR using autogenous and xenograft in central incisor sites. And now we're going to move on to a slightly different approach or a different way of using our xenografts. I'm going to be showing you 2 cases or 2 posterior mandibular cases in which quite an advanced horizontal atrophy is presented, and how this is corrected first by using autogenous bone, and then which way our xenograft can enhance our results. So on this first patient, we can see there's very, very little attached gingiva. There's a shallow vestibulum, very thin tissues, and there is a very pronounced horizontal atrophy. The density of the bone is also very, very low. And my goal, to place implants will be to reestablish the width of that ridge. So I want to grow bone as wide as that yellow line. That's my goal. On the cross section, this would be the more mesial aspect. This is where the bone is thinnest. I have placed a 3.5 millimeter diameter implant virtually, and clearly I need to build up bone in the buccal area that's going to be able to give me those 2 millimeters of buccal bone around my implant. From a frontal view or a panoramic view, whenever we have to graft bone horizontally, we know that most of our defects will be combined. That means that whenever we have a horizontal defect, most likely we're going to have some kind of vertical defect as well. So now we have the opportunity, we have the chance, why not, to try to correct those 1-2 millimeters of vertical deficiency that we have in the area as well. And for this, I'm going to be using the best bone graft or best biomaterial available. This is also evidence-based. It's called the split bone block technique, in which we're going to harvest an autogenous bone block, and then we're going to split the bone block into thinner plates. And those thinner plates, similarly to how we have used the xenograft as our cortical layer and autogenous bone as our cancellous layer, we're going to use, in this case, those plates to recreate and reestablish the cortical plate that's missing and any spaces that we created underneath will be filled with autogenous bone. Sorry. Great, so here you can see the process. On the right side, the first plate has been placed, which will allow me to grow bone horizontally. And you will appreciate there's a space between the plate and the host bone. So all that space is going to be filled with autogenous bone. And on the left side, I'm going to be applying a lid over all this just to contain everything and to avoid displacement of the biomaterial, which is the autogenous bone chips, and also the invasion of soft tissue into the site. So this kind of graft can be just sutured over. A membrane is not mandatory, and we allow this to heal for 3 to 4 months. So in a very short period of time, we're gonna be able to grow bone or create bone in a very predictable way, and we're gonna be able to get the best bone quality possible, which is 100% autogenous bone. Now, 4 months later, you're going to see that there has been some changes here, okay? And some changes that if we compare to the start, if we compare to how we started, and you see how the bone has adapted and resorbed, you're gonna start to question yourself a few things. But let me explain this, okay? So in 4 months, we can see that the more crestal plate has thinned down a bit, and buccally there has been some resorption as well. And this is the big limitation we have with autogenous bone. It's the material that gives us the best bone in the shortest period of time, but we cannot really grow bone outside of the bony contour. On the left image, on the baseline photo, if you look at how wide or how thin the ridge is where the premolar is, okay, that root of the premolar is over or outside of the bony contours. So distal to the root and mesial to the root, my ridge is quite thin, okay? So I try to go on from like a 6 millimeter wide ridge to 8 or 9 millimeters wide with autogenous bone. So I'm trying to create something that was never there. It's an anti-natural situation. So what the body has done, it has just resorbed it to the original contours of the bone. So on the right side, 4 months later, you can see that I have reestablished the contour of the bone, but I have lost volume because I started in a position where there was never bone before. I hope that makes sense, okay? But that's a crucial aspect or factor to be successful with autogenous bone and to understand why this kind of resorption might happen. Still, I can place my implants completely surrounded by autogenous bone. So the implants cannot be healthier or happier than surrounded by 100% autogenous bone. But in order to maintain this bone long term, and in order to have that 7-8 millimeters of ridge thickness, now I can apply some xenograft. Now is the time to use that biomaterial that if it becomes integrated, it's going to allow me to maintain space and it will not resorb. And this is also evidence-based. It's also been described by Luca Vestavola and Joachim Tunkel. So what they were aiming or they were trying to show is how to achieve long-term protection of this regenerated bone. And simply by using a thin layer of a xenograft, this bone that's underneath is immature, but it's also very, very active. It has a lot of potential, a lot of vascularization. Now is the time to apply a xenograft, and we have better chances of that xenograft becoming incorporated and allowing us to maintain and protect all the volume that we have created. And why not use cerabone plus, which is going to make the procedure quicker and easier, and it's going to allow me to keep all the particles in one place. We allow this to heal for additional 3 months, okay? And as we started with a very, very poor situation of our soft tissues, we had to correct them. So at 3 months, remember that xenograft that we have placed, it won't be integrated yet. So we had to be working at a tissue level. We don't want to be exposing the xenograft that we have underneath. The implants are healed, integrated, so we can start restoring them, but we don't want to expose the xenograft. So what's going to happen next is we're going to perform a soft tissue procedure to increase the vestibular depth and the keratinous gingiva. So on the right, you're going to see a partial thickness flap, a minimally invasive exposure of the implants just by doing small little crestal incisions over the platforms. And onto that periosteal bed, we're going to now suture a nice thick gingival graft. So this will allow me to get tissue thickness as well as tissue height, which is a concept that's becoming more and more important. We are more aware of the need of tissue height around the implants, but we're going to also create keratinous gingiva. So this will allow the patient to have masticatory tissue in the area, not just thin mucosa. The patient will be able to eat properly and brush without feeling thin and delicate tissues there. And we're going to also deepen the vestibulum. We allow this to heal for an additional 6 weeks, and this is the result. So we've gone from a very thin ridge to have a bulky, thick, strong, and healthy soft tissue around our implants. And once we get here, we can finalize the case in a very, very nice way. So you can see the before and after by using autogenous bone first to create bone quickly in the best way possible. I've been able to place my implants, add a bit of volume with a xenograft to protect what's there, but additionally increase the thickness of the crest. And with a soft tissue procedure on top of all that, I have reestablished completely the arch or the shape of that edentulous area. And this is very, very interesting. So whenever we have these kind of procedures or cases, to see what's happening underneath is very interesting, and it shows us a lot. We learn a lot from looking at these CBCTs. Okay, so from an occlusal view, we have the before and after, but what's more interesting for me is to see how my implants, they have autogenous bone on the buccal side, and we have a very thin layer of xenograft just containing and holding everything on the external area. So we have about 1-2 millimeters of xenograft on the buccal area. And in the cross section, we compare the before and after. My implant is completely surrounded by darker bone, which is the cancellous bone. The cortical plate that was crossing that purple implant in the pre-op scan has disappeared. So it has been erased. And the body is recognizing the outside or outer area as the new cortical. And also what's very interesting is to see how from a narrow base, okay, I have about 6-7 millimeters of bone width on the apical area. I've been able to rebuild and recreate bone that's wider on the coronal aspect than on the medial or the more apical part. And that's simply because I've added a xenograft. I've added something that the body's not able to resorb once it becomes incorporated within the bone. So for cases like this, where we are dealing with narrow bone patients with thin biotypes, these kind of xenograft materials will allow us to push the envelope a little bit and try to get outer and get thicker or stronger results around our implants. We're going to finish up with the last case. I have a little video ready on this as well. And the starting point is quite similar to the case I just showed you, okay? But the approach I'm going to follow has a few small differences, and I would like you to pay attention. So we again start from a ridge that's very, very thin. We have no attached gingiva, very shallow vestibulum, very thin tissues, and the bone, the ridge is very thin as well. This is just coronal to the mental foramen. So this is the second premolar region. We have 2.7 millimeters of bone. You can appreciate also the bone in this case is very, very dense. There's very little or no cancellous bone in there. Okay, it's purely corticalized bone. And we're going to move on now to see how the case was developed. Okay, so I was explaining to you that for me, in these cases, the best way of predictably creating bone that's of the best quality possible and in the shortest period of time is by using autogenous bone. Okay, so the first step we're gonna follow. The first step we're gonna take here is to harvest a nice bit or nice cortical block from the retromolar area. You can see the process, how using the piezo unit and a chisel, I'm gonna be able to fracture away. I'm gonna be able to harvest this nice corticalized block. Once we've obtained the block, then it's going to be split into thinner plates. And with those plates, I'm going to be able to reestablish, to recreate that very thin ridge into a wider area. As any procedure we do in these areas, we're going to go gently, okay, just making sure that our block is free now from the remaining bone, from the host bone. And our objective, our goal should always be to harvest cortical bone. We're not interested in the cancellous bone that's underneath. And that's the secret, or that's one of the rules to stay safe, stay away from the underlying nerve. So that's a nice start to our procedure. Now that has been thinned into plates, and I'm going to be fixing the first plate. So as in the previous case, you might have noticed that I was placing my plates beyond the limits or beyond the contours of the original bone. Here I'm taking a lot of care on keeping my bone completely within the contours of the original bone. So the mesial aspect of the plate is completely aligned and completely flush with the distal bony peak of the canine. Okay, now I'm going to tell you that by doing this and growing bone to about, I'm going to get a ridge that's going to be about 6-7 millimeters, no more. But that's because the patient in that area had 6-7 millimeters of bone, no more. And we can see that by the remaining bone we have in the sides and by looking at the width, buccolingual width of the bone where the canine area is, okay? So implants, sometimes they can survive, teeth, they can have little bone buccally, they can have root adhesions buccally, but we cannot afford that with implants. But I know that if I'm trying to build up more with autogenous bone, it's going to end up resorbing. So I'm going to stay within the bony contours, even if I don't get those 7-8 millimeters of buccolingual width initially, okay? So once we are fixing the first plate, we're going to add a second screw distally. We're going to make this very, very stable. And as I'm fixing that plate, you can see how distally the space between the plate and the host bone is increasing. And that's because naturally the jaw is getting wider. So we have to try to follow the contour of the jaw. We start from a narrow area distal to the canine, and it's going to start to widen towards the molar sides. Very important to use screws that are purposely designed for these kind of procedures, that are very easy to use and non-traumatic. Now with 2 screws, that's going to be very, very stable. It's going to be no movement. Here, I have placed a second plate distal to the first one, and that second plate is also widening away from the base of the original bone, and that's creating a bigger space between the plate and the jaw bone. So as we have a bigger space here, I'm going to place a lid on top just to protect the graft or particulate graft that's going to be underneath. Okay. More mesially, I don't have much space to pack autogenous chips into. So even if I have 1-2 millimeters of autogenous bone or chips exposed, I'm going to be comfortable with that. But here distally, I do think that I benefit a lot from just adding a lid, and that's going to add additional stability and additional contour to my ridge. And this is the last step. So all the spaces that have been created, now they had to be filled with autogenous bone chips. I use nothing but autogenous, no biomaterial, nothing that's going to slow down the remodeling of my bone, nothing that's going to slow down the creation of new vital bone. We're going to place those chips around all the different openings. We're going to try to fill everything nicely. And again, once we've done this, we don't need a membrane. We can simply close over. These chips, they can come from thinning down the plates, for example. They can come from further scraping on the distal area, but always from the cortical aspects of the bone. And as the osteocytes in them will start to die off from the transplantation, they're going to start to release loads of growth factors, BMPs, which will be creating an incredibly osteoinductive graft. So all that in the osteoinduction will start to trigger a response in the body. The body will recognize this as a need for new osteo or new mesenchymal cells to start to differentiate into osteoblasts and to start growing bone into the area. And that's the principle behind this technique. Very quickly, I'm just going to go through these two images so that you can understand where I'm standing here, and you understand how or why I'm creating or placing my plates this certain way. Okay, so I was saying I don't want to go beyond the original bone contours, and by doing so, I'm going to end up with a ridge that's about 6 millimeters wide. Okay, it's not a huge amount of bone, but it's going to be the best bone quality possible. So on the left image, you can appreciate how the plate is completely aligned and flush with the bony peak distal to the canine. And then as I go distally, that widens up a little bit. On the right image, you can see how on distal I've added a second plate on the buckle and one more lid, a lid on the top. Okay, so this is now my rebuilt ridge, and we allow this to heal for 3 months. And in 3 months, the CBCT is very interesting again. So look, this is the area just above the mental nerve where I had 2.7 millimeters of bone. We have now 6 millimeters. But you imagine if I've had gone to 8 or 9 millimeters, the bone where the mental foramen is narrow, and then it would be shaped like a sandclap. And that's just not, it's not stable long-term with autogenous bone, because the body will feel as that's something unnatural. We never had bone there before, and it's going to resorb it. Okay, so I can only grow bone within the contours of the bone predictably. So that's what I've done here. And this is the beautiful image 3 months after the procedure. Okay, so you can see how the screw heads or the heads of the screws are completely flush with the bone levels. Perhaps in the more mesial screw there has been about 1 millimeter of bone remodeling, but everywhere else, firstly, the bone plates have disappeared. They have incorporated, they have been built into the new bone completely. So that tells you about the amazing regenerative potential of this technique, okay? And second, there has been very few volume changes because I'm not pushing the envelope. I'm trying to grow bone with autogenous within the bone contours. To finish this case, okay, we're just going to see how the implants are being placed. And for this, surely first, the micro screws or the fixation screws will be removed. Every time I remove a screw, there's a beautiful bleeding coming from the bone, and it just looks like vital, perfectly autogenous, natural bone here. And this is the best bone to place implant into, because I won't have displaced particles. I won't have areas where the bone is just doesn't look like real bone. Okay, we're missing 4 teeth, or we're going to replace 4 teeth, the 2 premolars and the 2 molars. And the plan here is to place 3 implants, 1 in the first premolar area. I'm going to avoid the mental nerve foramen or the exit of the nerve due to the lack of height there. So we won't place an implant in the second premolar, and then I'm going to place another implant in the first molar and on the second molar. And it's going to be a case of splintered implants using multi-unit abutments. The drilling just feels like going into completely native bone, okay? There's absolutely no difference here in between the grafted and the non-grafted areas. The density of the grafted bone is also very high because it has turned over into perfectly living bone very quickly. And with patience, with a lot of precision, because we don't have a very, very thick ridge, okay? With a lot of precision, we're going to place the implants in the middle of the crest. Of course, prosthetically guided. We're going to check always the parallelism, make sure that we are good, that we're happy. And after completing the osteotomies, the implants will be inserted. Check the buccal, but also the lingual as well. It's important. Make sure that we are well aligned, well in the prosthetic corridor. And this is the first molar implant. The pins allow me to check the position again. And here, this is where we had a lid. Remember, we had the buccal plate and the lid. Everything has been remodeled very, very nicely. distal and mesial to the implant, you can see the screw holes of the fixation screws. Everything is perfectly integrated. Even the density of the bone here is very, very high. It's exceeding what the implant transporter can handle. So that broke off, okay. Just making sure the implants are at the right depth. Now, at this stage, this is the time to tackle those 6 millimeters of ridge width. First, before that, I was explaining I like to do my periostal release. So that's the management of the lingual flap. You can see how I'm vertically stretching that flap up, okay? No matter what kind of regeneration procedures we are doing, we have to be able to manipulate the flaps and the mandible. We have the advantage of being able to manipulate the lingual flap as well. And next, you can see how the buccal flap is completely advanced. So I can overlap both flaps very, very nicely and very gently, taking great care of not damaging the mental foramen. Great. So my implants are completely surrounded by 100% autogenous bone, but we know that buccal to those implants, I don't have more than 1 millimeter, okay? So yes, they're within autogenous bone, but long-term, I need a bit more, okay? So here, again, I'm gonna compensate for that with the xenograft, with the cerabone plus. The membrane is gonna be always fixed first in my hands, okay? Placing, doesn't matter if it's a sticky bone or something in there, it's gonna get displaced, okay? So I always place my pins first. I place them on the more apical area to prevent the bone graft to go any further apical, and it can disturb the mental foramen. And to say that in the mandible, sometimes it can be a bit challenging to fix the pins due to the density of the bone and due to the difficulty of getting perpendicular with the pins, especially in the more distal areas, because the lips, the cheek of the patient will be on their way. But again, like everything we do with patience and with determination, we can get there, okay? So I'm just checking my membrane, making sure that I'm covering all the area that I want to graft. And following the principles of the Stavola and Tunkel, we're going to do the xenograft relining now. This distal pin is the most challenging one because of the direction. It's very difficult to get perpendicular. And if not done right, the pins can easily bend, and sometimes they can break as well. Sometimes a trick can be to do a small perforation on the bone, and that's going to facilitate, it's going to make it easier to insert the pins. But with good retraction, a bit of patience, I managed to place that pin in as well. And a third pin will go just coronal to the mental foramen, because we want to contain the graft above the mental foramen. I don't want displacement of the graft beneath the membrane and into the deeper tissues, okay? First, because I don't need volume down there, and second, because it's going to put compression on the mental nerve. So I'm going to try to pin the membrane on the more apical area and stretch it so that all the graft is completely contained against the mandible, the side of the mandible. So this first bit here, it doesn't look like cerabone, okay? What that is just autogenous bone from slow drilling. Way through it, if we can use it, okay? It's not the autogenous bone that has the best, most osteoinductive osteogenic potential, but look, we just add a thin layer of it first, okay? Instead of throwing it to the bin. And I'm gonna use it where the bone is thinnest, okay? Where I need the best bone graft material possible, okay? So we're gonna use it more mesial in the area of the 4 and the 5. So that itself is adding me another millimeter or so of bone volume. And once that's ready, once that's in, now the next step will be to incorporate or to add the cerabone plus. Again, by having this sticky form of the biomaterial, it's making it much easier for me. Any bleeding that's in the area, it won't be displacing the particles. The particles will be all binded together, all compact, and that's just saving me time. There you see, simply with a little spatula or periostal elevator, I'm able to transport the cerabone, and then gently I'm going to start to adapt it. Try not to displace the autogenous particles that I have underneath, okay? But I'm going to try to take the cerabone all the way to the bottom of the membrane, and then from there I'm going to start stretching the membrane over and around it, just to nicely shape and compact all this. Distally, remember, I don't need that much additional width, okay? But it's more in the mesial aspect that we have to try to obtain those 7-8 millimeters of ridge width. I don't like to over contour too much either, so I don't see the need for it. And the more pressure we have in the area, the more possibility of displacement of the graft once we suture everything. So ideally, I like to have 1 to 2 millimeters. I think I'm happy with that, and that's plenty. And the same way that we have fixed the membrane in the buccal, we're going to have to fix it lingually. Here, it's quite difficult to use sutures lingually because we have released the lingual flap. It's not fixed and rigid like the palatal flap. So I was using sutures on the palate in the previous cases, but here I'm going to have to use tacks, okay? That can be sometimes a bit challenging as well. Any excess or any bit of graft, I think it's just unnecessary. I'm going to remove it as well. And this is another nice feature of the Jason membrane. Once it becomes hydrated, it becomes somehow transparent. So we can see where our bone is going. We can adapt it very nicely. Because some membranes, they're thicker and opaque, so you can't really see through them. But here I can see exactly where my bone graft is going to. Good. So I'm going to pin the first membrane. It's going to be lingual and a little bit mesial to that first implant. And you have noticed perhaps that I'm stretching the membrane as well. And that stretching causes compaction. It causes just a perfect adaptation of the granular material onto the host bone. And it's also going to minimize displacement and loss of graft particles. Because believe me, there's going to be pressure in this area. The cheeks will move, patient will chew. All this pressure can affect a graft. Mesially, we're fixed. And distally, we're going to do the same. We're going to stretch it lingually and distally and pin it down. These pins on lingual, which are more coronal, I would remove them usually in the second stage. So when I'm going to do my exposure and my soft tissue management, I would remove them. Whereas the buccal apical pins, they're going to stay there. I will not expose that area to remove the pins. Great. So that's the case now ready for suturing. The graft is now perfectly adapted, contained, and protected. And just as a recap of the case, okay, so we did a bone graft. We went from a 2.7 millimeter ridge to about a 6 millimeter ridge, enough to place my implants into perfectly living, healthy, vital bone, but still not enough, most likely, to long-term maintain those implants in perfect health. So here, a xenograft would allow us to get that objective, okay? So I'm adding that extra bit of volume, that extra bit of protection, and trying to prevent any further loss of my underlying graft. Great. So I hope it's been informative, this session, okay? I've shown you two similar cases in the central incisor areas and another two cases in the posterior mandible. The posterior mandible were treated with slight differences, and I tried to highlight that as well. And to conclude, I would like to say that cerabone Plus makes the bone particle handling easier. I save time by applying all the particle in one big unit, or all the particles in one big mass. I avoid or I minimize the displacement of the particles everywhere, and adapting this bone to the host site is much easier. I can also say that xenografts have their indications, so they are great materials used properly. If we are looking to obtain volume, we are looking to obtain contour augmentation and stability of a graft, they're very, very good, but they also have their limitations. Okay, we cannot rely on xenografts completely for every single of our regenerative cases. It would just not be predictable. Autogenous bone is the gold standard, 100%, but it also has its limitations. Xenografts can offer very successful outcomes in conjunction with autogenous bone. So what I was showing in the first case is in the aesthetic area is how we add a first layer of autogenous bone and a xenograft on top. By not placing xenograft directly onto titanium, which is going to be a dead space, there's going to be zero osteogenic potential in there. We first place a nice bed, a nice land of autogenous bone, which is going to be rich in stimulation, in growth factors and all that. And that's going to also help our xenograft get better incorporated and integrated into our bone. And advanced autogenous bone grafting procedures can benefit from xenografts. So sometimes, and I've seen this in my experience, many clinical cases, autogenous bone on its own might not be sufficient to maintain the bone that we have created, or might not be sufficient to achieve our goals. So we can combine these kind of techniques with xenografts, as shown by Stavola and Tunkel, very, very successfully, and get great results. I hope this has been informative, that you're taking home some nice tips. I would like to thank you all. And also, if you have any questions, you can feel free to drop an email. I'm also present and active in social platforms too. So thank you very, very much for your time, and see you soon.